to talk about side effects of atypical antipsychotics. So here's just an intro to some of the services that we provide. And just to start off with, this is important for many different reasons. Um, as we talk about atypical antipsychotics, they're often becoming increasingly used, and there's a lot of side effects that can be managed and also impact other medical conditions. So we want to know what are the common side effects of atypical antipsychotics, and even if you're a therapist, it's sometimes helpful just to say, maybe you should talk to your pediatrician about your weight gain, or if you're having trouble with falling asleep or feeling too tired. So even as a therapist, it's helpful to try to redirect your clients to speaking with their pediatrician about it. A lot of these atypical antipsychotics can cause um, increase in weight, increase in blood fats, increase in blood sugars, and there are actual guidelines in measuring these labs for a certain period of time. And some side effects just come with medication and are manageable, but other times you do need to adjust the medication. We'll talk about that. And we'll also talk about which medications in this class are have fewer side effects, and which and optimizing which atypical antipsychotic would be right for which patient. Um, Here's the atypical antipsychotics that are commonly used. Of all these, Abilify and Risperdal are used most frequently. The ones that are in bold are the ones that are in common use in child psychiatry. Often this happens in those with autism, bipolar disorder, disruptive mood dysregulation disorder. They're often used in MDD with psychosis or MDD with irritability, and sometimes they're even used for things such as insomnia. So they're used for many different indications in child and adolescent psychiatry, but the ones in bold are the ones that people are most familiar with. So this is probably the most important slide of the entire presentation, and we're not going to go through it in depth, but it's important to use this as a reference. And this slide I got from the um, textbook for child and adolescent psychiatry. It's by Dawkins, and it basically shows you the common side effects that happen with atypical antipsychotics and its prevalence or chance of symptoms for each given antipsychotic. So this is really helpful for determining which atypical antipsychotic would be best for a child. For example, if you have a 14-year-old with autism and who already is having a high BMI, then olanzapine or quetiapine may not be a good fit because it has really high weight gain with it. And Abilify, or which is aripiprazole or lorazepam, could be a better fit. Um, Also, if you have someone who has had a lot of trouble with being tired, feeling fatigued, then lorazepam, which is Latuda, or quetiapine, which is Seroquel, may not be the best fit. So oftentimes when, let's say we have someone with bipolar disorder or severe mood dysregulation disorder, and they're constantly showing up to either Rockford or Meadowood, and a mood stabilizer is needed. The, the thing that helps guide psychiatrists and PCPs the most in choosing the atypical antipsychotic is the side effect profile.
I'll get that stuff put away.
So if for people like even for people with bipolar and they have a comorbid eating condition, a medication like olanzapine can be helpful. Or if they have trouble with sleeping, the sedation properties of quetiapine or Seroquel can actually be helpful. So there's some side effects that travel together. Diabetes, hyperlipidemia, sedation, and weight gain usually travel together because they're all part of the same receptor, which is the antihistaminergic or antihistamine receptors into anticholinergic receptors. And then other things that can sometimes travel together is akathisia and orthostasis, or actually just akathisia and extrapyramidal side effects, which isn't listed here. But akathisia, which is like a sense of restlessness, can also happen as well. So we're now going, so this is mostly for people's reference later on, but this guide can be very helpful for determining which mood stabilizer or atypical antipsychotic could be useful in the future. So now we're going to go over the most notable side effects and most common ones. This is the ones that people most complain about, or most report, and are the reasons why people discontinue them. A lot of children report complaints with sedation, and this is why a lot of these medications are given at night. But Seroquel is the most helpful for sleep. And then the ones following it are Latuda, which is lorazepam, olanzapine, which is Zyprexa, and then ziprasidone, which is Geodon. And like I said before, this is mostly due to the histaminergic impact of these medications. And yes, please feel free to and ask any questions in the chat as they come up. The other most common side effect is unfortunately weight gain and elevated blood sugars and blood fats, which we all group together as the metabolic side effects. And the olanzapine tends to be the worst, with quetiapine or Seroquel the second worst. And then something else that really needs to be monitored, and it's also unfortunately common, and I see it on a regular basis, is with risperidone and paliperidone. These two medications are actually related. One is a metabolite of the other. Both of these can increase prolactin through their dopamine blockade, and in increasing prolactin, they can increase breast tissue mass and even cause galactorrhea. So a lot of times this has been a problem with adolescent boys, and it has been striking, and it also has greatly even impacted children's mood if they develop the side effect. So as soon as you hear a child or adolescent talking about chest pain or increase in their chest size and they're on Risperdal or paliperidone, that's a good indication to start trying to taper off the medication. So here's the metabolic side effects that we talked about before. Unfortunately, these side effects are more common in the pediatric world than adults. And when I say follows adult pattern, I meant this chart, in that the medications that are likely to increase blood sugars in adults are also likely to increase blood sugars in children. The two major exceptions is aripiprazole and risperidone, which coincidentally are the two most commonly used in children and adolescents. For reasons that we don't fully know yet, in children, these two medications are significantly more likely to cause weight gain than in adults. And this is something I often have to talk about with my residents, is because a lot of residents who initially trained in adult recognize Abilify as more weight neutral in adults, but in kids, it becomes much more likely to have a weight gaining side effect. And the same is true for risperidone. So I grouped them from the weight gain risk from very high to lower. Clozapine I put in because of its um, high use of treatment-resistant schizophrenia and bipolar. It's one of two medications that decrease suicide risk, or that have the greatest evidence to decrease suicide. So it's a very powerful medication, but it's also likely to have a lot of side effects. And I already mentioned the histamine blockade that decreases um, or that increases weight, but also it does impact liver metabolism. And one possible theory that um, olanzapine increases weight is that it induces protein kinase C beta um, genes, which can lead to more pre-adipocytes. Um, and even in kids and adolescents whose weight doesn't change, they still are at risk of developing elevated blood fats. So that process is most likely related to the glucose and lipid metabolism within the liver that these mood stabilizers can still impact. And if you notice, the medications that are likely to increase weight are also likely to increase blood fats and blood sugars. This is the second most important slide of the whole presentation, in that for people who are on mood stabilizers or atypical antipsychotics, they do need metabolic monitoring. Unfortunately, we have seen a lot of weight gain and hyperlipidemia and pre-diabetics in the adolescent population at a much younger age than it normally would have been. And oftentimes, either from the psychiatry end, if they have a child psychiatrist, the scripts aren't given, or the parents are very busy. They don't go to LabCorp or Quest, and these things get missed. And oftentimes, people can go on years without checking the blood sugars or blood fats. It's also very important to check height and weight at the 3 month mark, because a lot of the weight gain that comes from these atypical antipsychotics occur in the first few months. There are also quite a few kids who have developed hypertension while on atypical antipsychotics. So it's important to measure that at the 3 month mark and then annually. For those that haven't seen this term, and we'll talk more about this later in the presentation, but AIM scales are also important to measure the extrapyramidal side effects of mood stabilizers or the atypical antipsychotics. And by the extrapyramidal side effects, it's mostly the movement disorders. So like the restlessness that I mentioned before, or acute dystonia, which is muscle tension, or rhythmic movements of tardive dyskinesia. This side effect is much lower than the risk of diabetes in this medication class, but it can happen more likely with medications like Risperdal, especially if you're taking risperidone or Risperdal for a long period of time. There are some predictors of weight gain. Women are more likely to get it than men if their parents have a high BMI, and if they have a dramatic weight gain after 1 month of medication, they're more likely to develop medication later on. So I brought up this study because it shows how rapid some of the weight gain can be. And this is one of the few times where um, they stopped the study because of the weight gain associated with olanzapine. And with olanzapine, even though it's highly effective for bipolar or disruptive mood dysregulation or even aggression, um, the average weight gain in adolescents was 13.5 pounds. Granted, there was a high variability with it, but it was a significant weight gain in only 8 weeks. And they were already measuring an increase in cholesterol, LDL, and liver enzymes with it. So it's something to just recognize as you start this medication to really focus on the weight gain or to monitor for the weight gain. There are a lot of strategies that can be helpful. Metformin is becoming more widely used, and the trick is with starting metformin 500 milligrams PO daily is that it must be done as you start the antipsychotic. It's most effective as a preventative measure, not as a weight reducer after the weight was already put on. So this is a lot of families are hesitant to start a second medication, especially because it's to cover a side effect of another medication. But I always have that conversation with parents when we add one of these medications to say, hey, there's this risk of weight gain. Here's something that we can do to help prevent it. Topiramate or Topamax can be helpful for weight loss. Addition of Abilify can sometimes be helpful at a low dose to reduce weight, or switching to Abilify, or switching to another lower weight gaining medication. And sometimes Abilify can be helpful as an add-on low doses because it's a partial agonist at the dopamine receptor. But the most important things, like with many other conditions, is scheduling exercise. Exercise is very helpful for anxiety and depression. As a matter of fact, exercise in some of the larger population studies out of Sweden, exercise is as helpful as an antidepressant for depression. And so it's not just helpful for preventing weight gain, it's also helpful for a lot of the mood symptoms and anxiety symptoms, but also monitoring diets and dietary counseling as well. This is a part that is still controversial because there's some recent data to point against the study, but there's some data to suggest that high potency atypical antipsychotics can increase the risk of all-cause mortality compared to controls. It's a high relative risk, but the absolute risk is still very low. But there are some studies that suggest that it can potentially increase all-cause mortality. But this is still a point of debate amongst child adolescent psychiatrists because there was some recent data to point against this. But I just wanted to also bring this up for PCPs. So just for sedation, the most sedating medications are clozapine and quetiapine. Latuda, olanzapine, and Geodon, which is ziprasidone, have some sedative properties. And some of them can even cause insomnia, which is risperidone, paliperidone, or aripiprazole. Clozapine is the most constipation-inducing, but of the common ones, risperidone or Risperdal can often do that. And there have been a few kids where that have had to take off of risperidone because of the constipation side effects. And a lot of times outside of Risperdal, it correlates with the anticholinergic impact. Some of these medications can also impact cognition. And a lot of times kids report that it feels like brain fog, where it's hard for them to plan, it's hard for them to focus, and sometimes they just feel mentally slower. So their working memory could be impacted. This is a side effect that is reversible, but usually there's no other thing that you can do about it besides coming off the medication. And then you can come off one atypical antipsychotic and go to another one, and the side effect will go away. So here's the extrapyramidal side effects that can happen, and this needs to be monitored through an AIM scale. The AIM scale, which we can send out at the end of this presentation, is about a 20-part questionnaire, which can be done in 1 or 2 minutes, which measures things such as mouth movements, extremity movements, um, finger movements, stiffness of the tongue, any jaw problems, or any jaw movements, because a lot of this can be caught early on, especially with tardive dyskinesia, because tardive dyskinesia is built up over years. And the AIM scale itself is important for insurance authorization. You need to get a baseline AIM scale before you initiate an atypical antipsychotic. And a lot of times there is a time difference for it. Acute dystonia is likely to occur within the first few weeks. That's sustained or intermittent muscle contraction, often with the tongue, mouth, or lips region, or it can be repetitive movements or postures. Sometimes this can be body rocking. You could also get akathisia, which is very similar to restless leg syndrome that is likely to occur in the first few weeks. You can get pseudo-Parkinsonism, which is most likely to happen after at least a few months. And that's looks like Parkinson's disease, but it's bilateral. This is more likely to happen in older people. And the other medication, if you have people that are on risperidone or paliperidone for long periods of time, like for management of irritability with autism or as an adjunct for depression, you can get involuntary movements of many muscles, but it's mostly the fine motor muscles like your fingers and the mouth and tongue. People are not aware that they have tardive dyskinesia. So it's usually something that other people around them notice, like, okay, Johnny's lips keep moving in a stereotypical fashion. He doesn't complain about it, doesn't seem to bother him, but he's drooling a lot, and other people notice the drool. That is more likely to be related to tardive dyskinesia. And it's built up over years because it really much depends on how much antipsychotic exposure they've had. And it's more likely to happen in women and people diagnosed with a mood disorder. But since it is cumulative and you start a medication as a teenager, it's important to give them that psychoeducation and for them to decide whether they want to start the medication by saying, hey, there's this long-term side effect. Some of these, the best done through discontinuing the medication or switching them. For acute dystonia, especially if they show up to your office reporting it, Benadryl or benztropine, which is Cogentin, can both be helpful. And then for the movement, the akathisia, you can start propranolol or benzodiazepines. And now there's some recent treatments that help tardive dyskinesia. It's on TV, but it's tetrabenazine or tetrabenazine. So there's some other neurological conditions that is associated with atypical antipsychotics. People often ask me about seizures, and the only one that is notable where you have to adjust if they have a seizure disorder is clozapine. But most of the other atypical antipsychotics, it has a minimal impact on lowering the seizure threshold. And if they have seizures, you don't necessarily need to adjust their atypical antipsychotic dose. EKG changes can often happen with some atypical antipsychotics. The most noteworthy one is QTC prolongation with Geodon. That's the one, if we go back to our original chart, has the highest QTC prolongation. Other ones can somewhat increase it, but as you start it, unless there's a reason to be concerned about the QTC, whether it's a comorbid cardiac condition, earlier cardiac malformation, a previous history of an EKG abnormality, you don't need to recheck the EKG beforehand. But if you have someone who already has a heart condition or a comorbid or a previous cardiac abnormality, it's important to check the EKG before you start a medication like ziprasidone or lorazepam or Risperdal. And if the QTC is higher than 500 milliseconds, I would avoid these 4 medications. And it's also important to check for early cardiac death in the family because that raises the risk of Holcomb or another congenital condition. But overall, outside of ziprasidone, the increases in QTC are not that significant. So here's the ones that are less likely to cause it. Noteworthy of which is Abilify. And for sexual dysfunction, they can often happen with a lot of atypical antipsychotics similar to SSRIs. The ones that are more likely to be present and the ones that we often use are risperidone and olanzapine. And sometimes to treat it just like with SSRIs, you can add buspirone or bupropion. I'm trying to be quick as we're running short time here. But we already mentioned the gynecomastia, which is the increase in breast tissue mass with risperidone. And the best medications to switch for that are Abilify or quetiapine. However, if for one reason or another they need to be on risperidone, they can start bromocriptine or amantadine. Excessive drooling is a rare side effect, but it most often happens with clozapine. I have seen it in risperidone, olanzapine, or quetiapine, and this often is alleviated by switching a medication or adding oral glycopyrrolate. Urinary incontinence is often a less common side effect, but I have seen it in my clinic, usually once out of every 3 months, but it's something to keep an eye out for if you see the side effect in your office. But this is often most associated with risperidone, olanzapine. And for the few people that are on clozapine, this can often happen at night. So I'm just going to go over some of the really rare side effects. This is more in the case study realm, but bruxism can happen, although it's more likely to happen in SSRIs, elevated liver enzymes, pancreatitis, priapism. A granulocytosis can happen in all side effects at a very low chance, but in clozapine, it is significant, and this is why there was the guidelines to check CBCs every week. And also body temperature dysregulation can also happen as well. Here are the rare medical emergencies where if you see someone with abnormal vital signs and motor rigidity, and they're having and their creatine kinase is elevated and they're very delirious and they're on an atypical antipsychotic, that's you need to go to the emergency room as soon as possible. And the same thing with serotonin syndrome. A lot of these atypical antipsychotics, even though they're not SSRIs, do have serotonergic activity. So if there's other serotonin medications on board, and again, if they have a mental status change and vital signs, abnormalities, and It has hyperreflexia, diarrhea, agitation, hyperthermia. That's also an urgent ED visit. So that's a quick whirlwind of the side effects of atypical antipsychotics.